welcome back to the Core Consults RX podcast. What is going on, farm enthusiasts?
I feel like you completely changed up the intro from the first 200 episodes we've done.
No, I did. I keep them guessing.
You're keeping it fresh.
Yes.
Yeah.
I started saying that I'll say something stupid like that every time I'm doing my recorded lectures for my PA students, and I'll say farm enthusiast, so then they'll make fun of me in class the next time. I'm like, listen, dude, I'm just trying to be super edgy.
I think you usually say, what do you usually say? Podcasting world?
Something like that.
Wow.
I don't know.
Yeah, big change.
Yeah, the problem is I couldn't tell you for the life of me what I said just now. I have to go back and listen to
Something about farm enthusiasts.
Yeah, something about that.
We're talking.
Farm enthusiasts.
We're talking to the agricultural world today.
We are. We're not talking pH.
Yeah.
So what's new, man? Anything good?
No, not too much.
Same old.
Same old.
Yes, sir. So we done. I know we've done a UTI episode in the past, but it's been probably a minute, right?
I didn't even look, but yeah, it has to have been a long time.
But this is an accredited episode as well, so we'll do a review of uncomplicated and complicated UTI. And if you are a free CE member and have an unlimited membership, or you have access to all of their learning content, you can get access to all of our accredited podcast episodes as well. Each one is an hour of continuing education credit for pharmacists and nurses. And so at some point during this episode, we'll give you a passcode that you will use to do the post-activity test, pass those 10 multiple-choice questions, and you get your 1 hour credit. And if you're not a member of Free CE, definitely encourage you to check them out. They have all kinds of great, learning opportunities, good content. Even if you don't need it necessarily for CE, I would encourage you to use it as a good resource to continue your education on your own. And with that being said, thanks to Free CE for continuing to work with us. UTI. Where do you want to start?
Well,
some definitions, maybe?
Yeah.
Let's get some definitions per chance.
What does UTI mean? It would be just like us to go through the whole podcast
and not define.
And not say what UTI stands for, which is urinary tract infection, and then specifically define what it means, which it needs a couple of things. It needs the presence of bacteria in the urinary tract that's not accounted for by a specific contamination, but it also needs to be accompanied by dysuria, urinary frequency or urgency, and or a suprapubic pain. They're kind of delineated by location. There's a lower tract infection, which you might refer to as a cystitis in the bladder, localized to the bladder, and an upper tract infection, pyelonephritis, an infection involving the kidneys. Some people might refer to it as a kidney infection. The lower tract infection they might call a bladder infection.
Yeah. And I think that's important too, because depending on which resource or guideline that you're looking at, it may be a little bit different terminology. Because Nicole and I were talking about this before we started recording. I know when I was in school, if a male patient had a UTI, it was automatically considered to be a complicated situation, complicated UTI. Whereas now, that's not necessarily the case. Again, depending on which group you're looking at or clinician you're speaking with, but we kind of have it separated into the acute simple and acute complicated. And the acute complicated UTI will often include pyelonephritis, like Cole was just mentioned, the kidney infection. And so from an acute simple cystitis, basically like Cole said, it's just confined to the bladder, whereas now complicated UTI is the signs and symptoms of a standard, uncomplicated cystitis, along with fever, which they define as having a temperature of 99.9 degrees Fahrenheit or more. If the patient has chills, rigors, significant fatigue, if they're having malaise beyond baseline or other features of systemic illness, basically. If there's any flank pain, if there's any costovertebral angle tenderness, pelvic or perineal pain in men, those would all be indications of an acute UTI. But again, notice that it's not all men are just automatically complicated cases now.
Right.
So it's a little bit of a different nuance.
I remember learning that same thing. And there's also special populations. I feel like I remember maybe this could be wrong, but I feel like I remember an elderly patient they would say was frequently complicated, and a pregnant patient was frequently complicated off the bat. And
I think they kind of
they just consider them a separate
special
category,
population. Yeah,
just to be aware of, kind of thing.
Yeah.
You can also be classified with recurrent UTIs, and they define this as 2 or more episodes of acute bacterial cystitis in 6 months or 3 or more within a year. They're characterized by multiple symptomatic infections with asymptomatic periods occurring between each episode, so it's not a continuation of the same one. It's clear defined instances. They have a couple of terms that they use that's kind of based on the infecting organism. There's reinfections, and that's when the subsequent infection is caused by a different organism that was originally isolated. The majority of recurrent UTIs are going to be a different organism than the initial UTI. And then there's relapses, and that's the development of repeated infections from the same initial organism. And if that's happening, it may indicate that there's a persistent infectious source.
Now, from an epidemiological standpoint, obviously UTIs are going to be a common occurrence, just in the general population. They are more frequently occurring in female patients just because of the shorter urethra. And 5% of females will report having experienced significant bacteria by high school graduation. And then 1 in 5 females will experience a UTI in their lifetime. And many women will also experience, unfortunately, recurrent UTIs, and that's going to be a higher risk for patients who did have a history of childhood infections as well. But recurrent UTIs is also more common in female patients as well.
Now, the elderly are kind of special in a different way in that there's not as much of a difference in rates between females and males, and the majority of them can be asymptomatic. And we may talk a little bit about whether you treat an asymptomatic bacteria or not if they're not experiencing symptoms. The incidence is substantially increased for patients who are in nursing homes. The risk increase is due to various comorbidities like obstruction from prostatic hypertrophy in males, poor bladder emptying due to prolapse in females, fecal incontinence if a patient is demented, neuromuscular diseases like strokes, and also catheterization.
All right, so from a pathophysiology standpoint, there's 3 kind of important factors to consider when we're thinking about the development or the risk of development of an infection. So the size of the bacterial inoculum, the virulence of the microorganism itself, what kind of resistance rates do they have, or they have any sort of like resistance mechanisms like beta-lactamase producing organisms. They have adherence mechanisms, cytotoxic proteins that they're able to release, things like that we would need to overcome with different types of therapy, and then also the host defense mechanisms as well. Does the patient have urological issues going on that would put them at higher risk for getting a UTI in the first place? That would obviously be a big factor in the occurrence of a case of a UTI.
Yeah, some of those in the urinary tract, some of those host defenses might be low pH, extremes of osmolality, high urea and organic acid concentration, glycosaminoglycan slime layer, which prevents the adherence of bacteria, a protein called the Tam horsefall protein, which is a glycoprotein produced by the ascending limb of Henle and the distal tubule that is secreted into the urine and contains mannose residues. Those can bind E. coli and kind of help prevent a UTI. Also immunoglobulins like IgG and IgA. If the bacteria reach the bladder, an inflammatory response is stimulated with the mobilization of PMNs, which are polymorphonuclear leukocytes.
Now, there are different risk factors. Cole mentioned obstruction already, but anything that is going to inhibit the normal flow of urine would be considered an obstruction. So like Cole mentioned, BPH in male patients, some sort of a urethral stricture or tumor, a bladder diverticula, or medications that have anticholinergic effects is another big risk factor, obviously, as well. And then, like Cole mentioned, also neurologic malfunctions from stroke or spinal cord injuries, things like that. And then catheterization, pregnancy, the use of spermicides are also other risk factors that we would consider for patients with especially recurrent UTIs.
There are some modifiable behaviors, things that you can change that might decrease your risk of a UTI. For instance, if you're using a barrier method contraceptive or a spermicidal product, that can increase your risk. So consider changing your mode of contraception. Increasing water intake. If you're not having an adequate amount of water, so if you're consuming less than 1.5 liters per day, increasing your water intake over that is beneficial. Do you drink a lot of water?
So I really don't. I mean, I try to drink some, but it's definitely not, I'm not somebody that has the bottle that walks around all day long and just constantly is drinking water.
If I don't specifically think about it and make myself do it at work, I will not drink any water.
Yeah.
I have like a diet soda I drink at lunch, but I could, if I'm busy, I will go the whole day without drinking any water. Then I get home and I feel terrible.
Yeah,
because I'm
your
dehydrated.
kidneys are shutting down.
Yes. I don't know. I don't really love water,
Even
though it sustains my life. I just don't love.
I'm just
love
not.
the taste of it.
I just don't really big fan of it.
Yeah.
It's
just bland.
Like, who does it think it is?
It's too bland. It needs to spice itself up a little bit.
That's why I only get my water with Crystal Light packets.
Right. Exclusively.
Do you use those things like to flavor it up?
No. I have a big tumbler at work that I drink, but I don't know.
You're a tumbler guy.
I'm a tumbler. Yeah. I don't know.
I feel like that's just, I would see it and then I'd be like, it's too much work.
Right. The Crystal Light packets.
Or just the tumbler in
the
general.
tumbler.
Because then I'd be thinking about, I've not drinking that much of that today.
Yeah. What do you drink out of?
I'll have a Dr. Pepper Zero and then, or
so you
like
don't
you
have,
said.
So you don't have anything that just has water in it?
No, not usually.
Okay.
I'll get a water bottle usually.
These are, the diet sodas are mostly water.
Mostly water.
That's what I tell my wife.
That's exactly right.
It doesn't go. But
she doesn't buy it. And the thing is, that's just the stone cold fact.
It's just the truth, man.
So it is what it is, I guess. So you can't win them all.
You can't.
But especially with your wife, that's the last time you're going to be winning an argument. Some myths. Did you already talk about these myths?
No.
Okay. Myths regarding recurrent UTIs or things that can put you at risk for UTIs. I thought this was kind of a weird section of the recurrent UTI guidelines that came out from the American Urological Association back in 2019. Just because you don't see too many guidelines, I feel like, that address a myth.
Right.
I feel like that's probably one of the first times I've seen this, but I like it.
You guys might be thinking this, but just so you know, it's not true, and we're going to make it official in this guideline.
Exactly. You might as well believe the Earth's flat. But there's some case control studies that they were citing in order to come up with these quote unquote myths. But basically, they said that changes in hygiene practices, avoidance of hot tubs, voiding before or after a sexual encounter, tampon use, and douching all do not play a role in recurrent UTIs, which there's definitely a few of those that I was really surprised by that. And they basically are saying that there's not enough evidence to say for sure in a guideline that they do.
So do you feel like there's not enough evidence for them to recommend doing any of those things, or
avoiding any of those things?
Or does it seem like they're saying like, no, this is just, the fact that they're referring to it as, they refer to it as a myth, or is this kind of how you refer to it?
No, I think if I remember correctly, I think I better check myself on that because it's been a minute since I looked at that.
They're just saying there's not enough evidence.
Yeah, so that's that's kind of what I'm thinking of. That's going to drive me crazy then. But yeah, so those things are basically, they're saying they have not enough evidence to support their use.
But for things that you frequently have heard of, it's not.
I mean, several of those things are on there.
Surprising that it didn't result in
and
decreased rates or something.
In my thought process would be talking to a patient. I mean, it's not going to hurt anything to do a lot of those things. So why, if they feel like it's helping, then
sure,
go for it.
As far as what organisms are going to be the culprit, there's one that is very much the most common, which is E. coli. In uncomplicated cystitis, it's going to be 75 to 95% of the cases, so the vast majority. In a complicated situation, it's less than 65%, so you're going to have to be thinking other things more often. Less common organisms for an uncomplicated UTI would be the Enterobacter, Klebsiella pneumoniae, Proteus. There's also Staph Saprophyticus. Uncommonly, you might see Pseudomonas, and you might be thinking that more often if a patient is, has a risk factor for that. And rarely you may see Enterococcus species. Very similar with complicated as far as the less common bacteria, Enterobacter bacteria, Pseudomonas, which would be more common in patients with healthcare exposures, Enterococcus, and then you can have like MSSA or MRSA staff to be aware of.
Now, antibiotic resistance, definitely something that you hear people talk about a lot, but I feel like this is a very good example of kind of how this can kind of play out in the real world. So from 2000 to 2009, there was a threefold increase in the prevalence of extended spectrum beta-lactamase producing Enterobacteriaceae in hospitalized patients. So huge jump in those ESBLs. They're basically 6% of these 453 E. coli isolates that they were looking at in this one study produced ESBLs, and that was in a specific patient group that was presenting with pyelonephritis to the ED. There's also some evidence showing the emergence of a specific E. coli strain, ST131, that is responsible for the fluoroquinoline resistance that's oftentimes associated with E. coli and UTIs. And then there's a VA study that also was looking at this E. coli ST131, and in their study, it accounted for 28% of the E. coli isolates nationwide. So very resistant. In fact, when I was in school, so this was on rotations, it was like 2014, I guess. I remember being in the STICU, and in order to use Cipro in the STICU, you had to get an infectious disease physician to like basically sign off on it, and there was only certain things you could even ask for it to be used in the first place, like if they had leech therapy, some random things like that, because the E. coli resistance to to Cipro was so crazy high in that area.
Really?
I don't know if it's still on restriction like that, but I remember it was like a really big deal to try to use Cipro.
Was it in South Carolina?
Yeah, it was Charleston.
Oh, really?
MUSA.
Oh, wow. We're just getting very specific now.
I mean, I was in school there, so I was just on
yeah,
rotation.
yeah.
And I don't know if that's I haven't looked at their antibiogram in a long time, so I don't know if that's the case. But
no, I think that highlights the importance of looking at your antibiogram if you're going to be dealing with this a lot. And, look at resistance maps. For instance, you can find a resistance map for E. coli to fluoroquinolones and other things based on your region and area and that sort of thing, to be aware of what you might run into, especially if there's a treatment failure. Something to highlight is VRE, vancomycin-resistant enterococci. It's frequently isolated in hospitalized patients and may be due to extensive use of kind of broad-spectrum cephalosporins like third-generation cephalosporin antibiotics. It's a major area of concern because of limited susceptibility to other available antibiotics that you can use. And it's become more widespread and more common in long-term hospitalizations or patients with malignancies. There's two specifically. I didn't want to try to pronounce them, but I guess I will. I guess it'd be Enterococcus facialis and Enterococcus facium.
Facium.
Okay.
Yeah, close enough.
Yeah, close
I
enough.
like it. I was better than I would have done. Because of all the different resistance, patterns that we're seeing and, the mutations and whatnot, antimicrobial stewardship is obviously a very important aspect of managing UTIs. And it's probably one of the bigger culprits, besides maybe like a sinus infection, for causing a lot of this resistance anyway, just because of the frequent antibiotic dosing for patients that maybe didn't even need it to begin with. But we want to reduce inappropriate treatment. So in other words, patients are asymptomatic. We're not treating them until they start developing those symptoms. We also want to decrease broad spectrum antibiotic use. If we do a culture and sensitivity report and we find out that the broad spectrum empiric therapy that we were giving is not necessary, we can de-escalate, then that's always a good idea. And then always treat the patient for the shortest possible duration, and always keeping in mind that resistance reduction, if at all possible, or resistance risk reduction, I should say.
These are important interventions that pharmacists can make, but it isn't also important to think hard about how you approach these sorts of things when a prescriber is trying to prescribe something. We're acting as like the antibiotic police,
Right.
Like, no antibiotics for you. We're not going to.
Well, actually.
Yeah. Just think about it.
Professional interactions need to be professional, and you'll be taken a lot more seriously.
I have a feeling that you may have a request of that provider at some point in the future.
Right.
So,
Gotta be nice.
Yeah.
Gotta always an interprofessional respect.
All be nice. The elderly and UTIs is a very important topic. We could probably do a whole episode on the elderly and UTIs, because UTIs affect the elderly in a much more significant fashion than they affect younger patients, which is probably why I have this memory of kind of considering a patient over 65 with the UTI as being complicated or at least more severe, because there's
so much stuff that can go wrong.
Some non-specific symptoms, some non-urinary symptoms that they can experience that the younger population will not. Altered mental status is extraordinarily common with UTIs in patients over 65. If you present to the ER with altered mental status or confusion, they're going to work you up for a stroke. They're going to work you up for electrolyte abnormalities. They're going to check your urine for a UTI because it's so common. They can change eating habits. They can cause GI symptoms. They can kind of give symptoms of complicated cystitis, even if it isn't necessarily. But they can have a frequent development of upper UTI with bacteremia. So definitely consider prevention and treatment of UTI in an elderly patient is a significant issue.
And we're trying to avoid the patient developing a severe UTI and having potential complications arise from something I don't want to say as simple as a UTI, but would seemingly, is a simple fix.
We generally think of them as being benign.
Yeah,
not always.
They can get some serious complications, associated with them if not treated properly, or if we don't recognize, the patient having a resistant bug or something like that. So bacteremia, sepsis, multiple organ system dysfunction, shock, acute renal failure, all things that we want to avoid. And if those things do occur, that would indicate that the patient does have a severe UTI, and we need to treat accordingly.
How the urine is collected is important too. One method is the midstream clean catch method. You want to have a clean urethral opening, void at least 20 to 30 milliliters of urine, collect the urine, process it or refrigerate it, or I should say process it immediately or refrigerate it as soon as possible, because if a specimen's left at room temperature for several hours, some bacteria can develop. It can cause a false positive result.
Yeah. I've seen... one of my family members was in a long-term facility. They were getting, they got the urine sample from her bedpan. And I said, I bet is that a clean catch?
That's clean.
Was that a clean catch? It's just been sitting there. Even my mom, who's not a medical professional, she's like, what are you doing? It was the most insane thing I ever saw.
Crazy.
Yeah. I was like, we have to get a urine sample to see if there's any bacteria. I was like, I'm going to go on a limb and say there's bacteria.
There's bacteria in there.
It's been sitting out for a few hours.
That's nuts.
But if a midstream clean catch method is not an option for the patient, maybe they have, a reason why they are just not capable of, coordinating that, catch. There's also catheterization. If the patient is not able to cooperate with the method of a clean catch, we can catheterize them and get their sample that way. If the patient is unable to void, it will, if they've had, if they've had their prostate removed, something like that, there can be some issues there that can make it difficult to void on command. And so that'd be another reason to do a catheterization method instead. And then the procedure itself is associated with 1 to 2% infection risk. So that's the other downside of catheterization, but other than it being uncomfortable and not very pleasant, it does have its own infection risk associated with it as well. And then there's also a suprapubic bladder aspiration, which is a direct aspiration by needle insertion in the bladder. So this would be, this would be if they had like unretractable foreskin, diarrhea that's, unrelenting, unsuccessful urethral catheterization, if they've had some sort of like urethral surgery, labial adhesions, labial edema, things of that nature. And have you ever seen like what that looks like, the suprapubic?
I haven't.
Bladder aspiration.
But this is how I know that I wouldn't have been able to really, maybe I could get used to it, but I wouldn't have preferred a job where I would be doing a lot of procedures. Like my little brother works in thoracic surgery. Mm-hmm. Because just imagining, like, the feeling of fullness in your bladder, like when you wake up first thing in the morning, you got to go to the bathroom.
Yeah. And
like any pressure there is just extremely uncomfortable.
Mm-hmm.
Now imagine that, but now they're shoving a needle into your bladder.
Or just, because how I am. I'm a half full kind of guy. What if
unless your bladder is totally full.
You know how like when you're like, oh my gosh, you get that relief after you empty your bladder. Well, maybe that's the feeling you get with this. You're like, okay, sure, there's a needle, there's a needle in my pelvis, but I'm all of a sudden feeling very relieved.
They're just they're pulling back the plunger, and you're like, oh,
you're like, this is perfect. This is great.
Exactly what I need.
I'm actually only going to empty my bladder this method from now on.
I mean, I will say that for people who are unable to void and have that feeling, I imagine it would be extremely, an extreme relief to have that done. But apart from that, it's
probably excruciatingly painful.
Yes, not great at all.
So this is a diagram of it from those of you who are interested, or if you have a New England Journal of Medicine subscription, you can see a video of them kind of walking through the steps. It's not too complicated, but also does not look like it's very comfortable.
It's not something I want to have happen.
Yeah.
Okay, so as far as the urinalysis after you get the sample and kind of evaluating it, they do a microscopic examination of the sample. As far as what you're looking for how much bacteria is in the urine. So 10 to the 5th power or more colony-forming units per milliliter is indicative of a UTI, though as many as 50% of women will present with clinical symptoms of a UTI, even if the colony-forming units counts are lower. There a lot of times hematuria can be present. You can have some blood in the urine. Some protein in the urine is common with infection, and that's usually transient, usually goes away. If it's persistent, it could be related to overflow, tubular issues, glomerular issues, that sort of thing.
And then there's also some other things to keep in mind, like so nitrites. Nitrates are formed basically when bacteria reduce the normally present nitrates in the urine. And so a nitrite would obviously indicate there's bacteria present. So a false positive is very unlikely. False negatives can occur, however, and it can be a gram-positive pathogen or a Pseudomonas isolate that they basically don't reduce nitrates, and so you wouldn't have that nitrite being positive on the urinalysis. And then we also have leukocyte esterase, which is just a rapid screening test. It's looking for pyuria, and it's very sensitive, highly specific, and that's another obviously a quick indication of whether or not the patient has an infection or not. And then we also have our culture, because if we, especially in a case where we can get a sterile, sample, a clean catch, so to speak, then we can run in the culture and susceptibility report. That way we know that the empiric therapy that we selected is accurate, or if we need to either escalate or hopefully de-escalate and use something with a more narrow spectrum of activity.
Yeah. And we'll talk about the specific antibiotics in a bit, but as far as some general things to consider with your treatment choice, it's individualized. You want to consider the severity of the signs and symptoms, the site of infection. Is it complicated? Is it uncomplicated? Does the patient have any allergies? Have they been compliant to treatments before? What are your local practice patterns and local resistance patterns with the antibiogram? Is the drug available? Is it high cost or low cost? And has the patient had recent antimicrobial use as well?
All things to consider.
Yep.
And I'll show you this right here for those of you who have not seen an antibiogram before, if you're watching the video version. So this shows you the different isolates on the left-hand side, and then across the top you see the different antibiotics that they tested against it. And basically we're the higher the number, the more or the more susceptibility that the pathogen will have. So it's antimicrobial susceptibilities. And so, yeah, the ones that have 0, I don't think we're going to use ampicillin on Acinetobacter. So that kind of makes sense. So if you haven't seen those, the antibiogram should be available at any of the big, hospital settings, or any big healthcare system should have their own version of an antibiogram based on similar resistance patterns and things like that.
Right. Okay, so we're going to talk a bit about asymptomatic bacteriuria, or I'll just talk about it briefly, which is more of an incidental finding maybe on a urine culture of bacteria in the urine, but the patient's not having any of the symptoms that we've gone through of a UTI. So generally speaking, treatment is not necessary in patients with significant bacteriuria where they're meeting that threshold of 10 to the 5th power or more colony-forming units per milliliter without the signs and symptoms of a urinary tract infection. There's not great data showing a benefit in treating these patients. There are certain exceptions where you might be concerned that even an asymptomatic bacteria could develop into something more significant, possibly pregnancy, if patients are undergoing a urologic intervention or renal transplant patients, you would be more concerned.
Don't want them getting pylo.
No.
All right. So before we jump into treatment of uncomplicated cystitis, let's give the super secret password because it's almost exactly at the halfway mark.
Nice.
So today's password is by UTI. So BYEUTI, all capital letters, one word, no space, and you'll have access to our super fun post-activity test.
By. Yes, not BUY.
Right. You don't want to buy one. You want to say goodbye.
Not BI.
Right. Because then you'd have that and something else.
But BYE.
Right. Because you have upper respiratory and upper urinary tract.
Right.
That would be a nightmare.
It'd be a double UTI.
So, yes. It's by UTI, BYE, UTI. And then we will be, you'll get your 10 question quiz and you'll blow through that because it's super easy and you'll get your 1 hour credit.
Yes.
Treatment of back to you. It's a treatment of uncomplicated cystitis. So we have our 3 first-line agents that we typically consider for an uncomplicated cystitis case. So we have our nitrofurantoin, monohydrate macro crystals, so the macro bid, basically the twice daily version of nitrofurantoin. And it's given for 5 days. There's very low resistance rates. It's very similar efficacy, if not even better efficacy than some of the other proven agents. And it is very effective for uncomplicated cystitis. However, if you are concerned at all about pyelonephritis or have any suspicion of pyelonephritis, you don't want to use nitrofurantoin because you will not get basically it out of the bladder. It's accumulating in the bladder, which is why it works so well for cystitis, but not going to help further up the urinary tract. And then we also have Bactrim as an option. So the Bactrim DS, which is the sulfamethoxazole trimethoprim, and you can do 1 twice a day for 3 days as well. Now, the thing to make sure that you are looking at is to make sure that there's no, or that the resistance rate, specifically with E. coli to Bactrim, is 20% or less in your local resistance prevalence. And then if the patient has used Bactrim within the last 3 months to treat a UTI, don't use it again because then that resistance rate is that much higher. And then third, we have fosfomycin, which is a 3-gram single dose antibiotic option. It tends to have a little bit lower efficacy than the regimens above, especially nitrofurantoin. It's been compared to head to head. And it's one that we typically will avoid an early pyelonephritis because of the low serum levels that we can reach with fosfomycin. And again, we have better options that are more targeted for that area of the body and better tissue penetration and all that. But either of these 3 options are technically okay, again, assuming that the resistance rates for the Bactrim are 20% or less. All 3 of these agents are potentially first-line options.
Yeah. Along with that is how macrobid works and some things to be aware of. I feel like it's used so commonly that we feel like it's benign, but it does have some warnings to be aware of. So it is metabolized to reactive intermediates that inactivate or alter bacterial ribosomal proteins. It inhibits protein synthesis, aerobic energy metabolism, nucleic acid, and cell wall synthesis as well. Warnings to be aware of: it can cause hepatotoxicity, can cause hemolytic anemia, peripheral neuropathy, and pulmonary toxicity. If a patient experiences a persistent cough, chest pain, shortness of breath, they should definitely call their provider. More common adverse effects would be GI upset, headache, and it can cause a brown discoloration of the urine as well.
I feel like the pulmonary fibrosis risk and things like that, that's not something we typically would worry about, obviously, in a 5-day course. But where I will say that I've seen a case of this anyway with pulmonary fibrosis specifically was when a patient was taking nitrofurantoin as a prophylactic agent. Elderly patient taking nitrofurantoin once a day, every single day for an extended period of time, months and months, if not a year, and developed pulmonary fibrosis due to the nitrofurantoin. So that's where I would say kind of have your those more severe warnings on your radar would be for those particular patients.
Sure.
So some other things to keep in mind with nitrofurantoin, if you look at the dose adjustments, if it'll say in the package insert creatinine clearance less than 30, we are not usually using, not because it's going to cause harm necessarily or worsen kidney function or anything like that, but we know that we're trying to get the medication to accumulate in the bladder. Nitrofurantoin is basically excreted through the urine unchanged, and so it does a good job of accumulating in the bladder if the kidney function is what we're expecting it to be for the patient. And so if a patient's creatinine clearance is less than 30, we probably would want to use a different agent just because the nitrofurantoin concentration won't be as potent as we would like.
Right.
Some other issues with nitrofurantoin, it can cause some GI issues, and not usually as bad as something like high dose amoxicillin or anything like that, but it can cause some GI issues with tolerability. And then the good news is much less documented resistance with nitrofurantoin compared to like Bactrim, and it is very bioavailable. Whether it's fasting, you actually get a little bit better bioavailability with food, and you can cut down on some of the GI issues. So that's probably a good idea to remind patients to take it with the meal.
Yep. Then there's Bactrim. Like Mike mentioned, the sulfamethoxazole piece inhibits folic acid synthesis. The trimethoprim piece inhibits tetrahydrofolate synthesis. It can cause GI issues as well. It can also cause skin reactions like Stevens-Johnson syndrome. Photosensitivity is common. Hyperkalemia is one that can be concerning, that it can cause. A short course isn't as big of a deal, but we've discussed data before that in combination with other meds can be concerning. It can also cause hypoglycemia, interestingly, but it has good oral bioavailability, 90 to 100%.
I looked this up one time because with the hypoglycemia risk, and it basically is working as if it's a sulfonylurea, and binding to the beta cells and to release that insulin.
Is that the trimethoprim piece?
Yeah, and so it's or no, I think it's actually the sulfamethoxazole piece. Now that I say that, but it basically has like sulfonylurea like characteristics, and that's what causes it. Because I saw a guy who was on glipizide, started Bactrim, and he was having like lows in the 40s and had no idea why. It's the Bactrim.
Huh.
So
interesting.
There you go. Food for thought.
Food for thought.
Here's another thing that kind of happened just recently. Somebody was telling me about a patient they had that had photosensitivity to Bactrim like weeks after stopping it, and I mean, horrible reaction,
Really?
blisters. I mean, it was bad. I saw the pictures of it. The patient's family member showed me, and I was like, wow, that is not. I was expecting like some red, photosensitivity kind of thing, red skin. I was like, wow,
Really?
That's a little more severe than I thought. And it was like 2 weeks after stop. I looked it up, and there's definitely case reports of that happening. So
Later.
thought that was interesting.
You want to hear something interesting?
Sure.
My whole family, extended and everything, went to the beach for a week.
Mm-hmm.
None of us got sunburned. We lather ourselves in sunscreen. Not a single sunburn the whole week. Isn't that crazy?
Well, if you lather yourself in isn't that the point of sunscreen?
I know, but for
I feel like
15 people,
I feel like you're
including children,
your disappointment is like it means you have no faith in the sunscreen.
I mean, I don't have a whole lot of faith in sunscreen, but I don't know. It's crazy that none of us just ran into an issue where it wore off or washed off or forgot to put it on. No sunburns.
Good job.
I've never had a trip like that.
Yeah, I always get sunburn when I go out, especially early in the summer.
You don't seem like a sunscreen guy.
Well, it's usually what it is. I'll be like, hey, tell my wife to help me out, put it on my back, whatever, and then I'll just get like handprints all over me because she'll just not do it right.
Anna, she used the spray one time, and I guess it was just a little bit too close, and so
you see the streak marks,
just lines, just a big zigzag of sunburn and no sunburn.
It's like perfect. I have a graffiti sunburn. Right. All right, so we got fosfomycin is our third option, like we said. This is working to inhibit bacterial wall synthesis by inactivating the pyruvyl transferase enzymes, which is critical for cell wall synthesis, and it's one of the rate-limiting steps. And so adverse effects, GI issues, nausea, vomiting, diarrhea, rash, headache, angioedema have been reported as well. It does have fairly poor bioavailability, poor oral absorption, and so it's got a bioavailability of around 37%, and it's probably why you have to have such a big dose all at once. But it's administered as a powder that's mixed in with 3 to 4 ounces of water. You don't have to take it with food, and but it can help with the GI issues for some patients. Where I would say that this may be a good option would be patients who you're real suspicious of their adherence rates. You're worried that if you start them on an antibiotic, they may not follow through, they may not finish the course, what have you. And so this could be a convenient one and done option and hopefully treat the patient.
Yeah.
It is a little bit more costly than the other two first line options. So you got to make sure the patient has good insurance and can afford it. But all three of those would be technically options that are all correct.
Yep. As far as first line, there are alternative treatment options like fluoroquinolones, which would be considered second line because of increasing resistance rates. Maybe we want to preserve them for more serious infections. They also have some additional warnings and precautions, adverse events to be aware of. But you could use Cipro 250 milligrams twice a day for 3 days, or Levaquin 250 milligrams twice a day for 3 days. If you happen to know that the organism is gram-positive, you can use Augmentin as first line, but otherwise it can be an alternative because the E. coli resistance rates in the U.S. are up to 40%.
Even with the beta-lactamase inhibitor.
Even
That's
with
crazy.
the beta-lactamase inhibitor.
E. coli, you did it again.
Coming back with a vengeance. But 500 milligrams twice a day for 7 days is what you would use. You can also use cephalosporin antibiotics like cefpodoxime, 100 milligrams twice a day for 7 days. I've seen that done. Ceftonir, 300 milligrams twice a day for 7 days. They're never first line for empiric treatment. If recommended agents can't be used, test of cure is recommended due to high recurrence rates.
And Cole mentioned some of the warnings and the concerns with fluoroquinolones, but just to kind of reiterate, mechanistically, fluoroquinolones are working on DNA gyrase, and so they are basically inhibiting the relaxation of the DNA supercoil, and so they're coming at the eradication of the bacteria from a unique mechanism of action compared to a lot of other agents. The problem is the resistance, like Cole mentioned, and then the plethora of adverse effects. So photosensitivity, QTC prolongation, pretty bad GI issues. It can cause issues with blood sugar management. And then the box warnings, there's so many. Tendon rupture, which, have you ever actually encountered anybody that's had that with a fluoroquinolone?
Mm-mm.
So I've seen it twice now. So I was like, first time I was like, okay, maybe it's not textbook. And then the second time I was like, yikes. We got to start telling people not to lift weights when they're on Cipro.
Was Aaron Rodgers taking a fluoroquinolone?
He might have. I'll call him.
Did you see what happened to him?
Yeah, his Achilles popped, didn't it?
Yeah.
That stinks. But yeah, one of them that I saw wasn't Achilles tendon. No,
Really?
It was a runner, and just nobody warned him. Another one was this real muscular guy, and I said something about the fluoroquinolone too. This is when I was like an intern, so I was so proud of myself. Told him about the fluoroquinolone and all that stuff, and so just take it easy when you're lifting and stuff. And he's just staring at me. He's like, "Are you serious?" And I'm like, "Mm-hmm." I didn't know what. I'm like, "Why?" I don't know why you're getting madder at me.
Are you gonna beat me up?
But he like rolls his sleeve up, and he had like this huge scar on his bicep because he had apparently been lifting when he was on the same kind of thing, sinus infection or whatever it was the previous year, and his bicep, like one of the tendons in his bicep went up. They had to fish it out of his arm.
Oh my gosh.
Yeah. So yeah, just give him nitrofurantoin. So lots and lots of different adverse effects.
At that time, every UTI in males may have been considered complicated, so you might be going straight to something like a fluoroquinolone. But now, uncomplicated cystitis in males, at least from some people who would say that empiric treatment with one of the first line agents for females, the macrobid, Bactrim, fosfomycin, could be a reasonable option to start with. If they have more severe cystitis symptoms or concerns about early involvement of the prostate, then you might go straight to fluoroquinolone. But otherwise, you can do macrobid. A 7-day or shorter course of the selected antibiotic is likely sufficient. That's notable because previously we would kind of consider longer courses for males. But you can do the course recommended for that we kind of went through for females. If you feel more comfortable, maybe a couple extra days. But 7 days or shorter is likely sufficient for males as well.
All right, so let's kind of go back through this algorithm a little bit. So we're using the up-to-date empiric antimicrobial selection for women with acute simple cystitis. If you want to reference this later on for those of you who have an up-to-date membership. So this is Basically, patients presenting with suspected cystitis, classic symptoms, dysuria, urinary frequency, urgency, suprapubic pain, things like that. Then we also want to look for any type of signs that the infection is extended past the bladder, the fever, flank pain, those type of things like we mentioned. And then also looking at the risk factors for multi-drug resistant gram-negative infection risk. And so, if they've been residing in a nursing home or a long care acute care facility, have they used fluoroquinolones or Bactrim, in the recent past, but within the last 3 months, if they travel for different parts of the world, they have high rates of multi-drug resistant organisms. And so, those things can be considered. And if those aren't really a risk, then we would look to give one of our first 3 options that we've kind of talked about: nitrofurantoin, Bactrim, and fosfomycin. If all of those are not possibilities for the patient for whatever reason, then we would assess whether we're going to go the beta-lactam route or the fluoroquinolone route, and that again would be patient specific and what kind of comorbidities they have. And if you do go the beta-lactam route with Augmentin or Ceftonir, like Cole said, make sure that you do a test of cure, just because there is higher failure rates with those types of antibiotics. A lot more resistance to worry about.
Yep. Is that all you want to go through with the algorithm, or
that's good for the simple cystitis.
Okay.
And then we'll go through the other ones as we go.
Okay. The last part of this we'll end talking about complicated UTI, including pyelonephritis. Empiric therapy must be broad spectrum, with definitive therapy based on the culture and sensitivity that you get later. There is a concern for overall rising rates of resistance in hospitals and in the community, especially resistance in patients who have received fluoroquinolone, so be aware of that. Outpatient management is acceptable for patients with an acute complicated UTI if it's mild to moderate, who can be stabilized, so they don't have to be hospitalized every time for a complicated UTI. But you would admit them in certain situations. So if they're septic or otherwise critically ill, you would want them in the hospital. Some of those kind of indications might be persistently high fever over 101 degrees Fahrenheit, or pain, marked ability or inability to maintain oral hydration or take oral meds. They would need to be hospitalized.
So if we're looking at the empiric therapy options for an acute complicated urinary tract infection, it's going to be different depending on whether we're treating the outpatient or inpatient setting, obviously. So in the inpatient setting, we're just, again, verifying that they have typical UTI symptoms plus the clinical symptoms of showing that the infections progress past just the bladder, the flank pain and all that. And then we would still want to get the urine culture susceptibility testing so we can double check our empiric therapy option and make sure that we made the right choice. And then we also want to look for those risk factors for multi-drug resistant pathogens. And from there, we would go with either the fluoroquinolone route, which we typically want to start with if they're is having some kind of contraindication to fluoroquinolone, if they have high risk for fluoroquinolone resistance, things like that, then we can go with something like ertapenem, carbapenem. It's a little bit more broad spectrum. If we're not worried about any of those fluoroquinolone resistance risk factors, then we can go with 1 dose of ertapenem, and then we would follow it with a fluoroquinolone for a few days, so the Cipro or Levo. Now, if the patient, and I'm sorry, let me back up because I think I maybe didn't say something that's probably going to be confusing now. So once you've gone through the diagnosis, you're saying, okay, this is an acute complicated urinary tract infection. The multi-drug resistant risk factors is what would push you down the path that we were just talking about. If they do have any of those risk factors, so that's where the ertapenem and the fluoroquinolone, would come in. If they do not have those risk factors, then it will be a little bit different. We are still looking at whether or not they could tolerate or should be on a fluoroquinolone. And if if they do have a contraindication or reason why they couldn't be, then you get one dose of a long-acting parenteral agent. So it can be ertapenem, it could be ceftriaxone, it could be gentamicin, and then you would follow it with a non-fluoroquinolone agent. So either Bactrim, cefpodoxime, you could use Augmentin, but again, because it's complicated and affecting higher up than just the bladder, you wouldn't want to use something like nitro or one of those.
Right.
And if they are not having a contraindication, or they don't have a contraindication to a fluoroquinolone, and you know that the resistance rates are not to basically below 10%, then we can do a fluoroquinolone as monotherapy. If the resistance rate, especially for E. coli, is above 10, then give them a loading dose of that long-acting parenteral agent. So the ceftriaxone, ertapenem, gentamicin, one of those, and then do the fluoroquinolone after that, orally.
And if you're kind of going broad spectrum and you get susceptibility results, you can de-escalate.
Yes.
So we'll quickly go through some specifics with some of the drugs Mike mentioned. So aminoglycosides, there's gentamicin, tobramycin, also something called plazomicin, which is IV only. But gentamicin and tobramycin are IV or IM. They interfere with bacterial protein synthesis. They bind to the 30S ribosomal subunit, and it results in a defective bacterial cell membrane, which kills them. They do have a few box warnings to be aware of: nephrotoxicity, ototoxicity, and respiratory paralysis, respiratory issues. So use with caution in combination with other nephrotoxic drugs. The ototoxicity, that can cause hearing loss. Early toxicity is associated with kind of a high-pitched sound. Vestibular toxicity resulting in balance issues, and they can cause fetal harm if given in pregnancy.
And then we also have our carbapenems. So we have doripenem, imipenem, meropenem, ertapenem, and all of these are potential options. We know ertapenem tends to have a little bit less of or a little bit more narrow spectrum of activity. Usually doesn't include things like Pseudomonas. And we do have to worry about some interactions, specifically that carbapenems can decrease serum concentrations of valproic acid. So if the patient is using divalproex, valproic acid for whether it be a mood stabilizer or is it for epilepsy, we could lose control of their comorbidity if given with the carbapenem. And we do know that from a seizure risk standpoint, if they have a history of seizures, or other risk factors for lowering their seizure thresholds, the carbapenems can also decrease that seizure threshold further and make that risk even more so.
Right.
Adverse effects, they're more common. They're beta-lactams, so we know GI issues are going to always be an issue. And then the patients who are also have CKD, just use some caution with imipenem because if they do have impaired renal function, especially with imipenem, they may have an even higher risk for that seizure occurrence.
Right. There are some situations where you may need to consider if the patient has risk factors for multi-drug resistant infection. If they do have those risk factors, then you may need to consider broad spectrum gram-negative coverage like cefepime, unless they have a risk for ESBL, piptazo, meropenem or imipenem possibly. If not, ceftriaxone, piptazo, cipro, and levofloxacin can be okay. But vancomycin, we're familiar with it. It inhibits bacterial cell wall synthesis, but can also cause ototoxicity, nephrotoxicity, and has an infusion-related reaction that can be common, as well as phlebitis. With it has a lot of monitoring that if you've worked in a hospital and a pharmacy, you're probably familiar with, but have to monitor renal function and do dose adjustments in CKD. You also need trough concentrations, which are generally drawn before the fourth dose with a goal trough of 15 to 20 micrograms per milliliter. And you want to use caution if you're giving it with other nephrotoxic drugs as well.
And then alternatively, we could also use, and it's kind of going in that same, if we're trying to cover for the gram-positive side, we could use vancomycin, but alternatively, we could use something like daptomycin, which is a little bit different of an agent. But the class is a cyclic lipopeptide. Mechanistically, it's inhibiting all intracellular replication processes, including protein synthesis, which eventually leads to cell death. The kind of unique thing about this is you do want to do weekly CPK checks because the risk of myopathies and even cases of rhabdomyolysis have occurred with patients taking daptomycin. It can also cause a falsely increased INR reading, and this is not associated with an actual increase in bleeding risk, but if somebody's on like warfarin therapy, it's going to definitely change how they're managed because we can't go up their INR like we normally would.
Right. There's also linezolid, which binds to the 50S ribosomal subunit. It has some monitoring involved because it can decrease platelets, hemoglobin, white blood cells. It can also increase serotonin levels, interestingly, and blood pressure when used with other adrenergic drugs. It can also cause peripheral neuropathy and optic neuritis.
All right. And let's talk a little bit briefly about the multi-drug resistant gram-negative bacteria treatment options that we have. So it's a more even broader spectrum of activity with these carbapenems with beta-lactamase inhibitors built in. So we have Vabomere, which is meropenem, and Vaborbactam. This does have very excellent empiric broad coverage. They can be used in patients who are severely ill. Typically covers Pseudomonas, and the Vabomere, the beta-lactamase component, is typically reserved for patients who either have or are at risk for extensively drug-resistant pathogens. So if the patient's not susceptible to one or more agents in all but two or fewer antimicrobial classes, or if the patient is found to have a carbapenem-resistant enterobacteriales, then that would be another reason why we would kind of jump to these more intense medications. Same thing with imipenem and relebactam. Ricarbio is the brand name. It's used for multi-drug resistant Pseudomonas, and it also covers organisms that express KPC+, which is the carbapenemase enzyme. Yeah. So the couple different broad spectrum options.
There's also an interesting option that kind of fits into that category as well, which is cefiderocol, which is a siderophore cephalosporin that is indicated for the treatment of complicated UTIs in patients who don't really have any other options. It has a novel mechanism of action for transport across the outer membrane that can overcome the effects of membrane permeability mutations like in Pseudomonas. Similar to the others, reserved for patients who are at risk for extensively drug-resistant pathogens, so they're non-susceptible to one or more agents in all but two or fewer antimicrobial classes, or they have carbapenem-resistant enterobacterales. It does have renal dose adjustments below 60 milliliters per minute, and you want to use caution if a patient has a history of a seizure disorder.
Now, if you suspect that the patient is that has a complicated UTI is infected with an enterococcus pathogen, or you have proof of that based on the susceptibility report, then we typically would transition to something like ampicillin, given as an IV every 4 hours, plus gentamicin for initial therapy. And once the patient has been on therapy for 48 hours, or once they're afebrile, then we would kind of transition them over to oral therapy, so in this case like amoxicillin for 10 to 14 days, assuming again that it's susceptible to amoxicillin. And then if patients, you're thinking along the lines of like Bactrim, just know that the resistance rates are much higher with Bactrim. So if again suspecting enterococcus, think ampicillin, gentamicin, and then transition to amoxicillin after that.
As far as how long you should treat, shorter courses like 7 days are reasonable if the patient improves rapidly. Longer courses like 10 to 14 days are more reasonable if severe initial presentation, if the patient presents more severely initially, or if they have a delayed response. Interestingly, the European guidelines recommend stopping treatment 3 to 5 days after elimination of the complicating factor, if it's like a catheter or a kidney stone or something like that. And then just some things to note. It's important to convert IV to PO when the patient shows improvement in symptoms, because there are issues that can result from having the IV placed and using IV medications plus cost. So if we can convert them to PO, that's important. And if symptoms persist to or worsen after 48 to 72 hours, you might need to do further evaluation, pelvic or abdominal imaging, get infectious disease to consult, something like that to consider.
Well, there we go. We'll
did it.
Recurrent UTIs. We'll get into some of that at another time, but that's at least our initial therapy for complicated and uncomplicated.
It is.
Hope we covered everything. If that made like no sense as I was kind of like working my way through those algorithms, if you're a visual learner like I am, like I said, UpToDate is the source that I was using for those algorithms if you want to take a look at them yourself. But if you, again, are a free CE member, make sure you claim your 1 hour continuing education credit after this episode. And make sure you check out our partner Pearls, which is a drug info app. They have all kinds of great algorithms and pharmacotherapy refreshers. So you can go to pearls.com/coreconsultrx and check out their free version of their app. And then also for those of you who like more structured lecture styles with PowerPoints and all that cool stuff, check out the Patreon, which has the pharmacotherapy lectures and PowerPoint slides you can download, practice questions, all kinds of stuff. And that is patreon.com/coreconsultrx. And at least for a limited time, for those of you who sign up for the Patreon and sign up for an annual subscription, which is basically you get like a month free if you do that. And so instead of $3 a month, it's like $30 and some change if you do the whole year. For those of you who are paying for the annual membership fee, Dr. Alex Poppin has given us digital copies of his book, High Powered Medicine, Landmark Clinical Trial Reviews, in order to thank you guys for joining the Patreon. We'll give you a free copy. So if you join Patreon, you pay the annual fee, send after we verify the membership and all that, we'll send you an email with a link that you can download the book. If you don't get it, definitely send me a message, but should be keeping up with all those. And if you have any questions for Cole or myself, make sure you reach out to us via email, social media platforms, the text, you get the phone number in the show notes, whatever floats your boat. We will do our best to answer in a somewhat timely fashion, or at least in the next 3 months. And thank you guys so much for listening, and we'll see you guys on the next episode. Have a good one.